I think we are going to start that session. My name is Patrick Berlin. I'm from the Department of Pathobiology at OVC, and I'll be chairing that session. Our first speaker is going to be Shawn Zentner from the Wellington-Dufferin Guelph Public Health Unit, and she's going to talk about prevention and management of vector-borne diseases. Just before she starts, I'd like to remind the speakers that we try to coordinate between the two rooms, so try to stick to the time you've been allotted. When I stand up, that means your 15 minutes are over, and it's time to think moving on. Okay. So Dr. Zentner, if you want to.
Now I'm going to ring the bell. Good morning, I guess. This is working okay. So, I'm Shawn from Wellington-Dufferin Guelph Public Health, and I thought I should take a couple seconds to say a few things that I thought of while I was listening. One was that Scott mentioned about collaboration, so partly I'm here because we're collaborating with U of G on some tick dragging that you'll hear about from Katie, and also Andy Papadopoulos is here, and we've worked with Andy and had students from the MPH program at U of G working with us on some of the work we do in my program areas and other program areas at the health unit. So if you were here for the sort of main speaker here, I'm going to really bring this down a notch in terms of academic rigor, and I figure the title of my slide and my presentation is a good indicator of that, because there's very few words and there's nothing in italics and there's no Latin or anything like that. So I'm going to focus on what health units do. So for the health unit folks, sorry, this will be not much new. And I'm going to focus on what we do in vector-borne, which is essentially West Nile virus and Lyme disease. And I thought it would make more sense to talk about sort of the legal and processes that health units and all health units have to do that we're mandated to do from our funding from the province. So, okay. So West Nile virus is, I got too many things here. I will, yep. Okay. I have a pointer, yes, I do, okay. So West Nile virus is basically from birds to mosquitoes to humans. That makes it vector-borne. There's the buildup in the bird population or amplification, and then the spillover, and these are the terminologies that health units use, not necessarily a terminology that you folks might use. Spillover from bridge vectors, which are the mosquitoes that don't bite the birds, but that bite us. And of course, there's some mosquitoes that do both. And you'll see in the stats here that the stats start around 2002, and 2001 was sort of the big influx of West Nile virus in New York State and the Eastern Seaboard, and then the next year it was here in Southern Ontario. So not many people, even in the health units, might know about this. So there is a regulation that came out in 2003 after we had the exposures in 2002. And I point this out only because, so I should use this, because it talks about the medical officer of health, and she's here today, and about required actions by municipalities. And the whole point is to decrease the risk of West Nile virus, and it's based on local risk. So those are things that you'll see I've addressed in some of the slides. And then another little thing, our health unit is an independent standalone health unit. I did start my career in Toronto, and in Toronto you maintain the catch basins in Toronto, and it makes it a little simpler. In most other health units, you don't own the property. That's the municipality is responsible for where the mosquitoes breed. So there's work that needs to be done to sort all that kind of stuff out. Just to show you that, I'll do this, just to provide a bit of academic rigor. This is the formula for measuring risk, and I'd go through it with you, but I've got no idea what it means. But I saw Curtis Russell is here, so he might be able to explain it. I really don't know any idea. So next slide is, going the wrong way. a slide that you can't see. But this is here because the risk, and it was mentioned in the regulations, there's this great big thing that is 2010, but it's kind of slightly updated through some other stuff. But in this document, which health units follow, is this slide. And what you can't see is there are risks of none, remote, low, moderate, and high. And then in here is a focus on the moderate and high. And the talks about whether or not there is epizootic in birds and horses, etc., and some of the actions you're supposed to do in terms of increasing adult mosquito control, advertising to the public about mosquito control measures and things you should do to minimize breeding sites. So again, that's part of the rationale for why we do these sorts of things in health units. Thirdly, the other thing that we have is health units have Ontario public health standards, and then we have protocols, and in the protocols there's this protocol, and this protocol talks about, sort of outlines the main points that you're supposed to do, and this is really the kind of, at this level, the sorts of things that myself as the manager in the program, we sort of focus on. And I'm going to talk mostly about the vector surveillance stuff that we do and the vector control program stuff that we do. What else was I going to tell you about this? Well, I think that covers it. The other thing is it's under the CID program, so ultimately this is a human health concern, and that's not my program. It's kind of rare that these progress to human health. Most of the work that we do in health unit is about the mosquitoes and the breeding sites. So vector surveillance. This is actual, these are people that we hire to go and do this stuff. So there's a larval collection and adult mosquito monitoring. And the adults, I think, I've got that slide next, I'll go here. So Wellington-Dufferin Guelph is a fairly big geography, health unit-wise. I don't know how familiar you are with it, so there's Shelburne up there, Elora, Guelph down in here. We go down to Puslinch just on the other side of the 401 before you get to Hamilton, and sort of the far out areas of Wellington here, Mount Forest. So we have a pretty big geography, and these are all of the sites where there are mosquito traps. So there's 12, and 168 as we do it typically for 14 weeks a year, and there were 7,800 mosquitoes last year. And also this is from that document, the preparedness plan. The Ministry of Health funds all of these programs that health units do, and they also outline the mosquitoes that are most relevant that you should be trying to catch and test for the virus once you do catch them. And here's the list of them. It's actually been a little bit recently, they've recognized about Eastern equine encephalitis, and so they've adjusted some of the ordering of the preferences to test for. Okay, so these are actually from 2014 from we have a third-party company that we hire to do this for us. They do the adult trapping, they do the larval dipping, and they do all the larviciding that occurs. So these, I don't know how much, if you paid too much attention to the list before, but more or less the people, the guys, the mosquitoes, girls actually, that were on that list are here. And the Culex pipiens in restaurants, it says enzootic vectors. They're actually both enzootic vectors and bridge vectors, and they're the main ones that all the health units are kind of watching out for. And then most of these other guys, of course, bite us, and then they pass on the virus possibly to humans. And you can see a bit of the triple E vectors there as well. So I really like this picture because, I don't know, just the perspective of the camera makes it look like it's a really boss motorcycle he's got there, but it's not. It's just a little scooter. So they literally go around and drop in these little pellets of larvicide into catch basins. We treated 22,000, and I wasn't sure if people wondered, because I did when this all started, why catch basins. So catch basins, there's a lot of them as you can tell. And then they're all designed this way with a bit of an overflow. So right now, when it hasn't rained for a while, well, maybe it has, there's a lot of standing water there, and it's easy to access catch basins. They're municipally accessible, and you can do them with a scooter. The non-roadside catch basins that you see listed here would be essentially in people's backyards. Standing water sites are often something like a stormwater management or retention pond, and the other stagnant water would be basically a swamp area. We do, and other health units I'm sure also have issues where you'll just have a big hole because someone was putting in a target and they went out of business, and now there's just a big hole filling up with water. So you do get that kind of stuff. City of Guelph, which is one of our partners, they do actually have a standing water bylaws, so we work with them and help them to enforce that, because if actually it got bad and we had a scenario like this, we could actually call that a health hazard under our legislation and give a little more oomph to their municipal bylaw. So that's it. And I guess I kind of want to touch a little bit earlier in the slide when I was talking about adult control. If you're keen on these things, there's adulticiding. We don't ever do adulticiding. I don't think a province has, but our mosquito larviciding is our adult control, and essentially the way that it works is it prevents the larvae from developing into adults. So it's adult mosquito control at the larval stage. I thought I'd talk a little bit about the process we go through. So health units aren't normally applying pesticides. The catch basins are on municipal property, so we send a letter to all the municipalities. In our case, that's around 19 or 20. We also send letters to people who have had their backyard catch basins larvicide, and there's a waiver to allow us to access that property. We need to authorize that pesticides are required, and this whole point back to the but an identified risk area is where our MOH has to say, yeah, there's a risk for human illness here. Then our MOH essentially has to request that we get a larvicide license, and we hire this other person to do that, and we attach that letter, which you'll see in a second, and all the other approval letters to that application, and goes to Hamilton to get a license to apply the pesticides. We have to put a notice in local newspapers telling people that we're doing this, and of course, in addition to municipalities, there's land on Hydro One right-of-ways, conservation authorities, that kind of stuff. So another letter that you can't see, but it does, just to highlight that it talks about authorization, it talks about on municipal and private lands, and it's a decision based on this preparedness plan. So that's how that kind of all is tied in and gives us our legal oomph and justification. Next slide is my favorite slide. This says 2013, and there's a reason for that. I could have chosen 2014 or 2015, because that's also gone out. But this one just happened to be next to the Manners Fantasy and Fetish Night when it was in the Guelph Tribune. So I thought I'd throw that one in there. So human surveillance, I won't touch much on. It's a reportable disease. And so it needs to be reported to the health unit. Most of the people don't really have any overt symptoms when they get West Nile virus, and if they do, it can last for up to a year, and then it involves sort of some more serious complications. And here's the 2002 year here, where we had the, I was going to call it a blip, I guess it's maybe a little more than a blip. Again, in a little bit in 2005, and then 2012 was another big year for all of the health units. This is Ontario data, and also throughout the sort of 2022 to now, there's been pockets where a few years ago there was a lot of West Nile virus in Saskatchewan, Manitoba, and the prairies. This is just Ontario, and obviously you can see that the humans and the mosquitoes curves essentially mimic it's the same. So, and speaking of the same, here are just for WDG from 2002 to 2015, human cases, and again 2002 and 2012 when there were a lot of positive mosquitoes, or when we saw some human cases. Not much though, just a couple of suspected cases, and those were in Shelburne and Palmerston. If you don't know our geography, that's actually sort of the far sort of north area. Typically, you might think it'd be more in the southern, hotter areas, not that it's that far north. Of course, the other thing is that you can have in your health unit jurisdiction suspect or positive cases where they didn't acquire the virus in your jurisdiction. So non-host stuff is next. And this is a bit old news because we used to initially use dead birds from the corvid family as the sentinels to say that, hey, the West Nile virus is coming because there was a dead bird. It went to the Canadian, which I'm sure when I started this had an extra C because it was the CCWHC, but the Canadian Wildlife Health Cooperative. And they would do the tests on behalf of everyone in the province, essentially. Now that it's essentially endemic in our area, that doesn't happen much, but if there is a bit of a bird die-off, I did it again, I can go back, then they would still be interested in knowing about that. So public education, I won't say much. We tell the people through media and our website to decrease standing water sites and to protect yourself from mosquito bites. Okay, Lyme disease. So Lyme disease is kind of the same thing, except instead of birds, we have deer, and instead of mosquitoes, we have ticks, and then we have people who get sick from it bridging over. Katie's here somewhere. She's going to be talking about this, so I don't think I'll spend a whole bunch of time on this. But we did, one thing I should mention though is that both the mosquitoes and the ticks, you probably know these things, they overwinter. So when spring comes, you just kind of start back over again. You're not starting from ground zero. Black-legged ticks are the ones we're worried about. They're found in deciduous mixed forest areas. They're on deer and small animals. Long Point was the place I always heard about ticks. I do a fair amount of camping, kayaking, canoeing and stuff, so I was aware of that. Now they're more sort of Lake Erie, Lake Ontario, and heading up the St. Lawrence. And most people who come across a tick have come across it from being in one of these areas. Here's a map, and I think I only learned this partly from chatting with the U of G folks a while ago that started our involvement in this, that there's a sort of a new sort of hotbed area up in the Hastings, Prince Edward County sort of area of the province. This map is about exposures, not cases, and there's a little graph showing Lyme disease in Canada and Ontario. Obviously, it's going up. The number here is 24, and we're around 100, so fourfold increase in about 10 years. I'm not sure why we don't have up to 2014, but hopefully, I was just going to say, hopefully it's still going up. But I say that selfishly because I've said that it's still spreading, so I might be wrong on that. So we do, the other thing I should have mentioned is Lyme disease. We don't do really much about that at health units. We get money from the province, in our case, $150,000, $200,000 or so, that we hire someone to do all the work, essentially the larviciding and the trapping and the surveillance for us. In case of Lyme disease, there's no budget for that. So we do essentially passive surveillance. Someone will bring a tick, we'll have a look at it. We are fortunate in that we have a staff member who has a background in this. He can identify if it's a black-legged tick or not, and then it gets sent off to Winnipeg to the National Microbiology Lab for testing. So talking to U of G, our area isn't really somewhere where you'd normally see ticks, but black-legged ticks. So, but they, of course, will fall off birds. They end up getting dropped off in an area, and if the area is suitable, then you might have them established. So, here are our black-legged ticks for our health unit. We don't have many, so 2014 there were 16 of them. Again, this is just through passive surveillance. This doesn't include all the ticks that might have been brought into us that weren't black-legged ticks. And of course, not everyone really knows necessarily to bring us the ticks. So these are the stats from 2015. We've got 26 already. Okay, I'm running out of time. 32% of them are the black-legged ticks. And 50% of those 26 were locally acquired. And just yesterday we had one on a dog that we heard about from a vet, and it was a black-legged tick engorged female. And that person was walking their dog in the Hannon Creek area. If you're familiar with Guelph, you know where that is, and lots of people walk their dogs there. The vector surveillance, we tell people and the public and doctors that you should watch out for these things, but we're suggesting in the next couple slides that maybe we should be shifting from passive to active. And so as we shift to that, we've been working with U of G to do a bit of tick dragging. Here are folks who did the tick dragging training at Long Point recently. They look like those guys in the commercial for that, the quicker picker upper or whatever it is there. Sponge towels, that's it. Yeah. So there they are, and this was actually a tick that we found on that day from the tick dragging training. And basically just essentially that we're now partnering with U of G. We'll see if this goes somewhere. It'd be nice if it turned into a bit of a long-term thing where we can repeat the sites just to monitor the spread. And I guess that's pretty much it. Yeah, okay, so there's some references.
If you have questions for Dr. Zentner, we have time. The other room is running behind, so we have plenty of time for questions. Yeah?
A sense of the proportion of ticks that are the exotic versus Center or other types of ticks, because this is one of the challenges is we might find one, so BLT as you're calling them, but what's the denominator of ticks?
I don't know. So yeah, that's part of like when we talk to U of G, at least to establish some sort of a baseline so we can go forward from that point. Yeah. Yep.
You were talking about adult and larval mosquito control. Is there any comparable control for the ticks? Like, is there something that we can do to try to control their population?
So I don't know the answer to the question. Our health unit response is we tell people to take preventive measures, to cuff their pants, wear light clothing so that you can see them. But I don't know about chemical control of them. Yeah.
Any other questions? We still have time, so feel free to ask questions.
I should have slowed down, I guess. Yes, Barb.
I'm not trying to give you a hard time. I just wanted to ask, what strikes me is removing the risk around some removing mosquitoes from important environments and over public health and access. Is there any discussions going on about all that does, or is that just not?
So if you didn't hear the question, it was about if we're killing a bunch of mosquitoes, is that a good thing because other life forms might rely on them. So I don't know if we're killing a whole lot of them, just focusing on the catch basins. And I guess I'll point it back to the legislation and the justification that the Ministry of Environment doesn't issue licenses to apply pesticides willy-nilly, so it's only because there's a human health risk that we do that. And I should have also mentioned too that in terms of applying the larvicide, the company that we hire, and all the companies really, they have a mandate and an obligation that when they're applying the larvicide to, for example, an open water course or a catch basin that's kind of the last in a string that might end up in a surface water stream, then they use different, more environmentally friendly options as the larvicides that they're using in those areas.
Any other questions? I may have one if nobody else does. You showed us numbers about the surface or the number of places you treat. What about private land, and when a private parcel is adjacent to a public place. What's the politics there?
There isn't much in the way of politics. There often is in public health, but we in terms of private lands, most of the places where the company does larviciding for us is because a municipality put in a subdivision. It wasn't well thought out. There's a lot of water that's there. They complain, and the municipality puts in a catch basin to drain the area. So now they've got this municipally operated catch basin on private property. So people are happy for the most part. This might touch a little bit on the sort of notion of killing mosquitoes. People are generally happy to have their areas larvicided, and then we do get, of course, you could have an area where someone's got standing water. You sometimes have this at the end of subdivisions where there's a lot of standing water around, and there will be complaints. But also the people who we hire, in our case it's Canadian Centre for Mosquito Management out of Winnipeg, they'll do larval dipping, and if there aren't mosquito larvae there, or the wrong kind of mosquitoes that we're not really worried about, that's usually unlikely, then they won't apply larvicide to those areas. But there isn't a whole lot of sort of neighbor stuff, or there isn't a whole lot of concern that we get from the approach that we and other health units take in terms of the larviciding of whether private or public.
Thank you. Any other questions? I don't see any, so thanks a lot, Dr. Zentner.
You're welcome.
Okay, so I think we'll have to wait for a few minutes that the other room get finished and that people can switch.